We will be talking about asthma with this talk. So the differential diagnosis for wheezing falls into two categories. First is acute, the second is chronic. When we think about acute, we think about asthma, bronchiolitis, bronchitis, laryngotracheal bronchitis, which is like croup, tracheitis, or foreign body. You will probably be most concerned with asthma, bronchiolitis, and foreign body. Croup sometimes as well. So for chronic conditions, we have tracheal bronchial malacia, which is probably one of the more common things you'll see. Vascular ring is always a good test question as well. Then you may see some vocal cord dysfunction and bronchiopulmonary dysplasia. But you can see the differential is quite broad. So predisposing conditions for wheezing or asthma, viral infections can induce an asthma attack, seasonal allergies, eczema. Family history can be significant. So one parent is about 2.5 times the risk, where 2 parents are 5 times the risk. Tobacco smoke and other irritants like perfumes, wood-burning fireplaces, that kind of thing. Weather changes and exercise. Things to key in on, you'll hear the triad. So seasonal allergies, eczema, and asthma, they all three go together. So try to remember those. As far as the pathology, you don't have to get this specific, but just kind of picture this in your head. So an allergen exposure leads to the IgE antibody being produced. This will join to the mast cell. Then a re-exposure occurs. And then what happens is histamine, leukotrienes, and prostaglandins are released, and it just causes chaos. So then you get smooth muscle constriction and bronchial constriction as a result. You get further recruitment of eosinophils, mast cells, basophils, all those inflammatory cells, which cause more of a reaction, and then the cycle continues. And so really when you think about the medications for asthma, you can pinpoint where each one happens. And so basically if at the bottom of the diagram where there's smooth muscle contraction, that's where albuterol is really helpful because it causes that muscle to relax. And then where there's other spots where on the circle where there's inflammation, that's where the steroids are going to help. As far as clinical manifestations go, 80% of the patients will have symptoms by 5. Cough and wheeze are the most common. Usually the cough is non-productive and hacking. And then you'll obviously see signs of respiratory distress, which can be retractions, shortness of breath, nasal flaring, chest pain, chest tightness, prolonged expiratory phase. And then you may see other signs of like eczema, allergic symptoms, that kind of thing. So remember, those symptoms are all kind of non-specific, but what will make asthma stand out the most from these other illnesses is how it responds to albuterol. So as far as how we evaluate a patient who we think has asthma, we go by symptoms and frequency to decide how severe the asthma is. We want to document if there's any reversal of symptoms with albuterol. If the patient's greater than 5, we can use spirometry. And so this is always a good test question. If they have a patient who's less than 5 or maybe developmentally delayed, they probably would not be a good candidate for spirometry because there is a developmental component to being able to perform the test. And then remember that the values are based on age, sex, height, and weight. And then we use an FEV1 of less than 80% of predicted, and then the FEV1 over FVC of less than 0.85. When you get into further details of how to diagnose the severity of asthma, you can see this complicated chart here. This is the foundation for our asthma action plan, which we'll talk about in the next couple slides. And so you can see that there's a lot of components that go into evaluating a patient with asthma. For me, I just use that top row where it says symptoms, and then it goes for intermittent asthma, the patient will have symptoms less than or equal to 2 days a week. For persistent asthma, if it's mild, it'll be greater than 2 days a week, but not daily. If it's moderate, it'll be daily. And then if it's severe, it'll be throughout the day. And so how I phrase this to patients is I'll say something like this, not counting this current illness, how many times a week do you need to use your albuterol inhaler? So remember, if they say less than 2 days a week, it's intermittent. Greater than 2 days a week, but not daily, is mild persistent. Moderate persistent is daily, and then severe is throughout the day. And then if you want to, you can get more specific when you look at spirometry values and nighttime symptoms, that kind of thing. So treatment, we can give albuterol numerous ways. That's the mainstay of our initial treatment. So it can be given through nebulizer, and that when we do that, we can give short increments of the dose, or we can give a continuous dose over an hour if the patient is really not in a good spot. And then we use inhalers quite a bit, regardless of the age of the patient. Depending on their age, we'll use a spacer and a mask. All patients you'll see will have a spacer, but then depending on if they're younger, you'll see a mask attached to that. The benefit of the spacer is it takes away the patient's need to be extremely coordinated when they inhale and press down on the inhaler to inhale the mist at the same time. So when you squirt it into the spacer, it all stays there aerosolized, and they can just take normal breaths and take in the medicine. When we look at our asthma action plans, remember it's based off of the evaluations that I just showed you, that table. So the green zone, or it's divided into 3 zones, green, yellow, and red. The green zone is the medications that the patient needs on a daily basis at their baseline. Yellow zone is what happens when they're flared up. So this usually means that a steroid is increased, or they're given a steroid if they don't normally get one. When we say that, we mean inhalers. We don't mean orally. And then the red zone is when they take oral steroids or IV steroids if they're in the hospital. And so when we look at the green zone plans, so your intermittent asthmatics, so those who have symptoms less than 2 times a week, they will just have albuterol before their exposure or with their symptoms. Again, if they are escalating, then they may be moved to a steroid inhaler. Your mild persistent patient, so that's the patient who has greater than 2 days a week of symptoms, they will get albuterol as needed, just like our previous patient, but then they will also have a low-dose inhaled steroid, such as Flovent, beclomethasone, budesonide, or mometasone. Your moderate persistent patients, so patients that are having symptoms daily but not throughout the day, they're going to have a higher dose of inhaled steroids, or they may have a long-acting beta agonist added to the steroid. So really, you're going to see more combination of medications in this area. And then your severe asthmatic, those are the ones you're going to refer to the specialist because their treatment may be more complicated. So when patients have asthma exacerbations, albuterol is always the first thing we do. Remember, it's going to cause that smooth muscle relaxation. And then they'll get steroids, either IV versus oral. Depending on how bad they are, if they're pretty bad off, then you'll see them getting sub-Q epinephrine and magnesium through the IV. Magnesium works also to relax the smooth muscles. And then, of course, every patient's going to be on oxygen and monitors. And so what you see when you get an asthmatic is that at first they start off pretty tight and they're needing frequent albuterol, and the steroids are being given at the same time. But it takes a good 24 hours or so for those steroids to start to kick in. Once they start to kick in, you notice that they're needing less and less albuterol because there's less and less inflammation and bronchial constriction. And so you can see basically that the albuterol need goes down as the steroid time goes up. So let us know if you have any questions, and that concludes our talk on asthma.